So welcome everybody to our COVID-19 Global Conversation Series, hosted by the Henry M. Jackson School at the University of Washington. My name is Danny Hoffman. I'm a faculty member in the Jackson School and the chair of the African Studies program. And it is my great pleasure today to be having a conversation with Rose Nakame, who is the founder and the executive director of the NGO REMI East Africa. And she's generously agreed to join us from Kampala. And so, Rose, welcome and thank you.
The pleasure is mine. Thanks for having me.
Of course. No, we're grateful that you'd be willing to take the time in what I know is a challenging moment for all of us. So I wanted to speak with you a little bit about the current situation in Uganda given the COVID outbreak. So maybe we could start by just giving us a little bit of a sense of what the current situation is. It seems like the Ministry of Health in Uganda is, at least the last report seems to be that there were about 81 confirmed cases in Uganda. Does that sound about right to you?
As of today morning, we have 83 cases,
okay.
52 recoveries, and 0 deaths at the moment. You're right in saying that the Ministry of Health is really running an aggressive or really aggressive at finding ways to contain this pandemic. But I think it's also more of trying to make it everyone's business to respond to the pandemic, from the citizenry to the whole government approach and the stakeholders involved. So if I could give an example, for example, just measures which were being put in place, the public health measures, the citizens, by obeying the lockdowns, they might not be obeying them to the T, but by making sure that they do their best in maintaining the social distance or keeping in their homes, they're doing their part in that way. But also, I should say, led by the president and the different ministers and cabinet officials, there have been a number of committees that have been put up, all geared towards to helping this response be what it is right now. For example, the scientific committee, which is made of academic institutes, both private and public, that are, for example, are finding ways to make low-cost diagnostics. Their target is around one which is less than $25, and that compared with the current cost, the current diagnostic cost globally is around $65, and so that would be one that is cheaper for the country to purchase, or even to make sure that more tests are available for everyone. And secondly, we have committees, for example, resource mobilization committees. And these resource mobilization committees are meant to be able to gear the citizens, and most especially also people who are among the top 10% of the pyramid, who are earning higher than the rest of everyone, to contribute their fair share to the financing of the pandemic response. And that has been successful to date, because more than $2.3 million has been collected in just that kind of encouraging citizens, encouraging the private sectors to donate, everyone just donating their dollar, or they, or just even what was shocking was just students who's just below 10 years just giving their $2 to the response, and people are motivated to give what they can to the response. It has its pitfalls also, the accountability, being able to account for where each dollar is going, but I think those are gaps that are yet to be addressed. And also the committees, interministerial committees that are meant to be able to, for example, help figure out how should the transport be, because to date, about, if you give a picture like 10 days before this date of the interview, most of our cases have been coming through land trade. That's the border trade that we do with our neighboring countries, and not within the country itself. Even our recent cases yesterday were from Kenyan truck drivers, for example, who are doing trade, and they're not coming within the community. And so the people who are seated and representing the transport sector on these committees, it's their job to try and figure out, and as of today, they release guidelines, for example, on how truck transport can be carried out safely. But it's a review back and forth process, because they try and put up measures. Sometimes they fail to control this. For example, the land trade and its effect on the increasing incidence of the COVID-19 cases. But I think it's a working process and that kind of a thing. And also there are measures in place, there are other efforts in place that are being done to be able to recruit the workforce that is needed in case the pandemic escalates. And about 120 healthcare workers are being sought to be added to the current task force. But also, if you're looking at it in terms of the health workforce, what they've done, because we do not have the right, we have, for example, a very low health worker to patient ratio. So if the pandemic hit us bad, as it is in the US or as it is in the European countries, we do not have the human resource in terms of the health workforce to be able to manage the pandemic, most especially if it becomes when most of the patients are turning into critical patients. We do not have that workforce. We also, our ICU beds, our critical care beds are less than 500 beds. So if we had critical care cases that are more than that, that will be a disaster case scenario. So the best case we have right now is to be as aggressive as we can to be able to limit this scenario from happening and contain this pandemic where it is right now. And I would say that comparatively, Uganda to its neighbors, Uganda is faring on well, because 83 cases compared to Kenya, which has around 396 cases, to Tanzania, to Rwanda, which has around 243 cases, and Tanzania not doing well. So comparatively, I think the measures have really been helpful in containing. There is much more to be done, but I think we're patting ourselves in the back and saying we're trying and doing the best we can as a country.
That's great, thank you. And I wonder if you could say a little bit more about that comparative question, because it does seem like Uganda is in some ways unusual in that both government and populace seem to have recognized early that there needed to be very clear measures, and there needs to be a kind of forward thinking about what might happen in a worst case scenario. So why in Uganda as opposed to the United States or other places where the political response and the conversation around the public health and political dimensions doesn't seem to be was a little bit slower to get developed? Why did it work in Uganda?
So comparatively, if you're to look at Uganda and the Western world, the US and the UK, they have a better health infrastructure compared to Uganda's health infrastructure. But the strength of the Ugandan's health system is it's used to dealing with epidemic after epidemic, and the pandemic came in when we're just right in the well of controlling HIV/AIDS and Ebola, the Ebola cases that we managed to make sure that we contain them to our friends in DRC Congo, so that they do not cross over to our border. Yellow fever and those kind of diseases, and managing TB. So the surveillance system is in place to enable us to pick up those kind of cases, be able to do quick contact tracing. other bits of it had to be figured out figured out with time. But for example, if I'm to give you a rundown of the timeline, for example, March 21st is when we detected our first case in Uganda. But prior to that, as early as January 20th, testing, that was like screening of people who were coming in through our main airport had already started taking place. Way in February 21st, we started having testing across the borders and screening of our patients. And this was quick. It was a quick measure to come in. The response was quick enough because this is a response we're used to from Ebola, and most of the healthcare workers who are manning these teams are used to it. I myself have been part of an Ebola response committee. So most of the people, it's just more of exercising the machinery, and as more as you exercise it, it becomes better. And the top governance of our leadership structure, except the ministers, but the president and the top ministers have stayed longer in power. So it has, if you look at it in the other sense of democracy and everything, it might have its worse effects. But if you look at it at gaining experience to be able to contain the pandemic and delivering what it needs to be done, I think that is where we could trust them to be able to know what to do at this time. But that doesn't mean the response is going on as smooth as possible. But at least that is one bit of it. And I think also another thing is the people who are making up these committees have done the work they're doing in other regard. I would say, if you look at, for example, the Resource Mobilization Committee, the people who are manning this committee have been able to exercise these same roles they're doing and increasing the finances for the response. In other areas, for example, in cultural events, where we, for example, we have here what they call a Kabaka Day Run, which is more of a kingdom run to get money to donate. For example, the last year it was around sickle cell disease, increasing testing of sickle cell disease. And these people are the same people who have been able to run this campaign successfully. And when you look at that and what is supposed to support the structures from civil society and everything, I think that is what contributed to Uganda's efficacy of the responses, taking the lessons, learning what we have done well in the past pandemics or epidemics, the Ebola, HIV, which is currently ongoing, and bringing those lessons right in and learning. I remember the first address the president gave to the nation. He was like, we just need to have the game plan and execute the game plan, because this is what we are used to doing, and we must do it well and avoid the worst case scenario for us. So I think that was it, and that's still the same game plan going on.
Okay, great, thank you. And I wonder if you could sort of, to follow up on that, I know that REMI East Africa, a big part of your focus is rural work in the rural health sectors and connecting. Absolutely,
right? Absolutely.
So, unfortunately, for better or for worse, on a lot of the global conversation about what COVID may do across sub-Saharan Africa has tended to focus on cities. But would you say a little bit about, is there a specific set of concerns to rural Uganda that gets overlooked in that emphasis on the urban?
So while the pandemic in most parts of the world, even in the US where it's hit first in Washington and New York, in Uganda, the way the pandemic rolled out across our different locations was, and while majority of the cases were in the urban areas, the cases were also spread across rural areas. And with the current incidences, we are having the cases arriving in at the border points. And so these are not entirely cities as per se. They are rural areas. It's just that at the area of no man's land, or area where the countries have no borders, that's where the trade is happening. But as they do the contract tracing, the cases the cases were coming in these communities. So what happens is in Uganda, the urban areas are more well equipped, more well resourced. They have a better, they have much more, the human resource in the urban areas is much more compared to in the rural areas. So when you look at that, the chances are that when the epidemic escalates to the rural areas, they're going to be worst hit. But if you also look at it in another perspective, is that 83% of Ugandans live in rural areas. 67% of these Ugandans who live in these rural areas are poor, living below $1 a day. So what is really happening to them as a result of these public health measures that are meant to maintain the pandemic is them complaining that they're dying out of hunger. Is them, most of them, we are having cases of mothers failing to reach the labor wards in time for their delivery. And there's so many who are going to die undocumented if these public health measures continue in place, because either they do not fit the case, the public case to be reported on in the newspapers. They're not high profile people, you know, that kind of a thing. And also, because of the situation these hospitals are in, they do not have the ICU infrastructure to manage the cases just like the urban areas. Luckily enough for Uganda, most of the rural areas have had not more than 5 cases, 1, 2, 3 cases. That's enough to pull even the not well-trained human resource in critical care to be able to manage that one patient. That has been the best case scenario. But if the case was worse, that wouldn't help. So what we're trying to do in REMI East Africa is we have time and again through our project, the Health Equity Voice, deployed the tool storytelling, which the Health Equity Voice project, which utilizes storytelling to be able to tell and share best practices within real time, what works in these low resource settings. As a healthcare worker who has worked both in the urban and rural areas, I'll tell you that access to what works in these kind of settings is very limited. And as you try and fidget with A, B, and C, you're losing a life. More so in this kind of respiratory pandemic where you do not know what works in these areas, you do not have the equipment, the ventilators are a few. Even what should help you, we have a story that we have just released today of one of our healthcare workers sharing how she never had PPE, personal protective equipment, just 5 days into managing a case. And she talks about going and deciding whether to take her staff to help feed the patient or allowing the patient to die and save the health workforce to be able to manage those who come in. That's the case scenario we are having in the rural areas. It shouldn't be, but that's what we're having. And unless these healthcare workers advocate for themselves and we amplify their voices, these stories won't be heard. There will be sacrifices that are made, but we are urging that the sacrifices that are made are humanistic in nature, that they take in account that all these people, whether they're poor, they deserve a right to health and well-being.
Thank you, Ebra. And that actually it brings up an interesting question for me. So one of the conversations happening in the U.S. is, you know, what does the trajectory of this outbreak need to look like for there to be a serious conversation around reform of the health sector, a sort of political,
Mm-hmm.
what does the cost
Mm-hmm.
have to be to change the political conversation? I wonder if you could say a little bit about, is that a similar kind of conversation happening in Uganda, or maybe just in your personal view, do you have a sense of what are the possibilities, the sort of, this isn't a very elegant way to put it, but what might be the positive outcomes in terms of thinking about how healthcare gets delivered differently in Uganda? What would that have to look like?
Mm-hmm. Mm-hmm. So that has been a conversation that we have been involved in for quite a time, ever since that project specifically, the Health Equity Voice project, started 2 years ago. I understand that in the US and in other countries like the UK, the people who are dying most are the poor and most especially marginalized populations, the African Americans, and the inequities are hitting them that bad. But I think also the conversation has been that here in Uganda, that health is looked at as a consumptive sector, one that does not have returns on investment. And I don't know whether there is hope of looking at this sector much better in the Ugandan context after this pandemic, because the country has been evolving epidemic after epidemic. But what has, I think, become so clear is to the actors who are involved in this health sector, for example, civil society, that there is an ability to tap into the private sector that we have not been doing really well to support the government efforts to be able to deliver quality healthcare. That in its sense has been, if you told me a month, last year, a month is too short, but last year or 2 years ago or 3 years ago, that resources in country will be mobilized to a tune of $2.3 million, I'll be saying, no, it cannot happen. I'll say the country cannot pull up to be able to do it. But we have seen members of the opposition party, members of the ruling party, pull up and be able to marshal the efforts towards this response. So that is something that I think as actors in the health sector that we need to now harness more, galvanize these efforts, and be able to see that there is an ability to put party lines separately and be able to marshal efforts to improve the health and well-being. But I think also, secondly, I would think that right now, what is also helping is because the government had to sit in an emergency redistribution of the annual budget to be able to channel most of the money back into the health sector and supportive sectors and pull the money out of the other sectors. Now, with a very lean budget, that means that the budgeting is going to continue as it should be when the pandemic resolves. But what would be something to go to would be my first earlier suggestion, that maybe we need to look at how we constantly galvanize the efforts of the private sector to be a supportive arm to the building of the health system. But that will only be sustained if we are able to build a more accountable and transparent system that is able to measure what comes in and what goes out, whether it delivers impact among the people, and whether it's able to help the country redistribute health opportunities among all. Because what has been obvious during this pandemic is, with the current closures of the airports and limited travel except for cargo across nations, is the top 10% of top 10%, those ones who earn the highest in our country, and those ones who have the highest social economic status, who can afford the luxury of going to more developed health systems and attain healthcare, they're all subjected to the same conditions as the rest of the population, to the most, like everyone. So what people are hoping is that they're going to realize that it might be the time for them to utilize the money that they spend on those kind of travels, on de-investing in the health system and the corruption that goes on, to be able to bring that money back and develop the health infrastructure. And lastly, I think the kind of in-kind contribution in form of motor vehicles, for example, that are being donated to the health system, some of these will stay and they might help in supporting the health system. There might be few, but those that have been donated in terms of hardware, for example, the donation of telecommunication equipment to the health ministry, enabling it to do Zoom chats, is going to continue. And those ones will be able to support the system to deliver. It might not be to the largest extent, but they might be continuously helping.
That's great, thank you. And I guess that my final question, I mean, I would love to end on a slightly positive note. So, but I do want to just ask, as somebody who's really on the kind of front lines of all of this, thinking and working in the health sector in Uganda, how are you holding up? Is this as a personal experience of the pandemic? Are you doing okay?
I would say, I think for me, earlier on before the first case, I was a little bit anxious because I was just coming from the US, and so I was a little bit anxious. Later on into the pandemic, we have work to do. I think it's the courage of all the other people at the front line that enables you to pick yourself up and continuously deliver through the pandemic. And amazingly, there are lots of social chats and people trying to keep the morale up to be able to work through this pandemic.
Well, Rose, I want to thank you so much for taking the time and sharing your expertise with us. And for those who are interested, there's more information about Rose, and both of our biographies will be linked underneath the interview on the website. But I just wish you all the best, to you and your family, your coworkers, and all Ugandans, as we all try to get through this. So thank you again for your time.
Thank you for having me. It was really a pleasure talking to you.